Now, EKG time. It's EKG time. Now, it's this woman coming in and says, which of the following is most likely to be found in this patient? Which EKG is most likely to be found in this patient? Let's start looking at our EKGs. EKG 1. Now, first of all, you could already decide in advance what EKG you expect a person with mitral stenosis to have. Now, I will tell you that I have not yet considered that atrial hypertrophies are your level of area. So I have decided that atrial hypertrophies is not your level of area. So, too hard. So just to make it easier for you here, we're saying what's the most common arrhythmia to be found in mitral stenosis? Let's look at the answers here. Choice A, okay? Choice A. Now with choice A here, what do you see? Do you see P waves? Do you see P waves here? See P waves here? Do you see P waves? I don't see P waves. You see P waves? I don't see P waves. I don't see P waves. I don't see P waves. What you see is fibrillatory waves. And you see an irregular R-to-R interval. See this R-to-R interval is not the same as this R-to-R interval. It's not the same as this R-to-R interval. Choice A, you see an irregular rhythm with no P waves. You see an irregular rhythm with no P waves. That's why this is atrial fibrillation. Next one, choice B. What do you see? Oop, hairline regular, R-to-R intervals, hairline regular. Is it narrow or wide complex? It's narrow, less than 100 milliseconds. Now, look at close. Do you see P waves there? Do you see fibrillation? That's not a P wave, that's a T. Do you see P waves? No. Do you see fibrillatory waves? No. Do you see flutter waves? Sawtooth? In choice B, we see a narrow complex tachycardia with no P waves, no fibrillatory waves, and no flutter waves. We see no P waves, no fibrillatory waves, and no flutter waves. So SVT is what we're seeing in B, supraventricular tachycardia. Best initial therapy would be adenosine. Most effective therapy, radiofrequency catheter ablation. Next one, choice C. Do you see P waves? Why, there's several P waves. Oh, that's a sort of P. That's a little P. That's a P too. That's a P. That's a P. You see, choice C has P waves, but they don't look alike. Ooh. You have P waves, but they don't look the same as your other P. Well, if you have P waves, and AFib. If you have P waves, it's not supraventricular tachycardia. You have P waves, but they look different from beat to beat. There are multiple foci of P waves. Multiple foci. Are there P waves? Yes, let's point them out. Are there P waves? Yes, that's a P. That's a P. That's a P. That's a P. There are P waves, but there are multiple different shapes. And there's a tachycardia, multifocal atrial tachycardia. Who gets multifocal atrial tachycardia? COPD. COPD. So multifocal atrial tachycardia could be treated with the same calcium channel blockers and digoxin as any atrial arrhythmia. The only difference is in MAT, multifocal atrial tachycardia, 3 P-wave morphologies, narrow complex QRS associated with COPD. The only difference is no beta blockers because it's no good for the COPD. Other than that, rate control. Rate control. Whoa, look at this thing in D. Look at that thing in D. Whoa, that looks like VTach. My goodness, look at that wide complex tachycardia. Wide complex, greater than 120 milliseconds. Each small box is 40. Each small box is 40. Wide complex, 120 milliseconds. Wide complex tachycardia. It's ventricular tachycardia. What's the next best step in the management of that patient? You see that EKG? Wide complex tachycardia? What's the next best step? You can't leave them like that. Can't leave them like that. You have to do something about it. Can't leave somebody like that. Their heart all flutter, hurting you. So what do you do next? If it's hemodynamically stable, You'd use medications. What's the best initial therapy? Amiodarone. Amiodarone, lidocaine, procainamide. But amiodarone is the best initial therapy. What else? You add magnesium. What's your favorite tocolytic? Yeah. Favorite tocolytic? Yeah. That's me doing premature labor. I know you think it's me doing Kegel exercises, right? Remember the innocence of our youth and all the carefree days when the hardest thing we had in life to do was just worry about the right way to do Kegel exercises. Well, it's not lost. Well, if this person is stable, amiodarone, lidocaine, procainamide, you add, what's your favorite tocolytic, premature labor? Magnesium. So you add magnesium to this VTAC person, particularly Torsade. VTAC, what's your favorite tocolytic? Magnesium. What is premature labor? It's Torsade of the uterus. What is Torsade? It's premature labor of your heart. It's a uterine arrhythmia. Premature labor. So this is VTAC, stable, amiodarone, lidocaine, procainamide, magnesium. Unstable, what do you do next? Shock it. Unstable, what do you do next? Shock it. What do we mean by unstable? When would you let somebody get you shocked? What do you have at home that can be just like being shocked? Something you can plug in? And the answer is the iron. I'm ironing, and ironing, and ironing, and ironing, and ironing, and I couldn't do that. I can't, I'm not saying never. I mean, it's too soon. I couldn't. Okay, hot iron in the chest. When are you going to let somebody do that to you? When the alternative is death, chest pain, not perfusing the coronaries, shortness of breath, not getting the blood out of the lungs. Hypotension, everybody's going to die. What does hypotension mean hemodynamically? It means a systolic blood pressure less than 90. Chest pain, can't perfuse my coronaries, going to die. Shock it, shock it. Shortness of breath, can't get blood out of my lungs, I'm going to die of hypoxia. Hypotension, systolic less than 90, systolic less than 90. Hemodynamically related confusion. You let people go around being encephalopathic, they're going to have a stroke. Chest pain, can't perfuse my coronaries, fix now. Shortness of breath, hypoxia, everything dies, fix now. Hypotension, which one? Systolic, diastolic? Systolic less than 90. Fix now. Hemodynamically related confusion, unlike the person who came up to me and goes, hey, Alzheimer's disease, they're confused, we shocked him? No. Anything else? How about urine? No. Anything else? How about urine output? Can we use urine output for hemodynamic stability? No. Because you need time to look at urination. You need time. You can't tell right now. You can't tell right now. You need something you can do to tell right now. Are you urinating right now? Are you peeing right now? Well, the answer is that you need something you can tell right now. How are we going to know? Choice D, to shock that VTAC. Chest pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion. That's when you shock. That's when you shock. Okay, next one. Final one, choice E. What do we see? What do we see? What do we see? We see, oh, wait a second. Oh, what's that? Oh, not that. Oh, wait a second. Oh, there it is. There's an RR prime there. You see that RR prime? V3, R to R prime is a right bundle branch block. Greater than 120 milliseconds, total R waves in V1 and V2. Greater than 120 milliseconds, total R waves in V1 and V2. Greater than 120 milliseconds, total R waves in V1 and V2, right bundle branch block. What is the pathologic significance of a right bundle branch block? What is the pathologic significance of the right bundle branch block? What do you do differently based on it? Nothing. What is the pathologic significance of the right bundle branch block? What do you do differently based on it? Nothing. Nothing. The right bundle. Left is evil. Left is sinister. Left is sinister. Oh, I made a funny What's the Latin word for sinister? For left. Latin word for left. Sinistre. Sinister. So, therefore, left bundle branch block is evil. Left, evil. Right, no big deal. Left, indication for thrombolytics with chest pain. Right, nothing. Left, indication for temporary transvenous pacemaker. Right, nothing. The right has the rabbit ears. Just think of it like this. Left bundle branch block, left sinistra, evil. The right, rabbit ears? Are you going to be scared of rabbit ears? I couldn't be scared of rabbit ears. Not dangerous. Now, the answer for this question, by the way, is EKG and A. The EKG and A, here we'll take one last look. The EKG and A shows no P waves. EKG and A shows no flutter waves. The EKG in A is a narrow, complex, irregular rhythm with vibratory waves. Oh yeah. Well, next person here. 25-year-old woman with rheumatic fever. Fever, no rheumatic fever, but no current fever. What's the most accurate diagnostic test? The most accurate diagnostic test is the cardiac cath. Left heart cath. Cardiac cath. Hey, I didn't say I do it, but it is the most accurate. What are you going to do? I'm not doing a left heart cath, not now. Cardiac cath. What's the most accurate? Cardiac cath. What am I going to do? I'm going to do an echocardiogram. What's the most accurate? Cardiac catheterization. Let's go down the line here. MUGA scan, nuclear ventriculogram, is the most accurate way, MUGA, of looking for ejection fraction wall motion. Ejection fraction wall motion. Answer E, Holter monitor. Continuous 24-hour ambulatory EKG monitoring. Holter monitor. Holter monitor is the better way to look for detecting arrhythmias because it records longer. Holter monitor. It's an arrhythmia question. The last one, dobutamine echo. Dobutamine echo is a stress test. Now, normal stress test should go like this. I go walking on my treadmill. And I should be able to detect the ischemia by exerting myself. I go walking on my treadmill. And I should be able to look for ST depression. Well, what happens if I can't read the heart with the EKG? I've got to find another way to look at your heart. Echocardiography. Dobutamine echo. Instead of looking for ST depression, I'm looking for decreased wall motion. Dobutamine echo. Oh, but what if I can't go walking, and I'm too tired, too lazy, too fat, too out of condition? I just don't want to use dobutamine with the echo. In general, exercise is always better than simulated exercise with medications. But when you can't get the exercise, time for us to do some drugs. Dobutamine echocardiography. Cardiac cath is the most accurate. What would I do? I do an echo. Next one, we're on here. Wow. Okay, last couple questions. And we have this person, and it says, which x-ray is most likely to be found in this person? Which x-ray? So this x-ray, I'll tell you what it shows. See over here? That left heart is way too big. That left heart is too far out there to the left. Choice A, the left ventricle is too far out there to the left. That's left ventricular hypertrophy. Next one. We have this big heart going too big between both sides. Now, greater than 50% of the total width of the mediastinum. That's how you know it's cardiomegaly. The heart should normally not be bigger than half a side of a chest. If the heart on the chest x-ray goes bigger than half the transthoracic diameter, it's cardiomegaly. If the heart is greater than half the total transthoracic diameter, it's cardiomegaly. This one is big, but it's going out big to both sides. This is like a dilated cardiomyopathy. This is alcohol effect on the heart. This might be a dilated post-myocarditis person. Next one. Ooh, look at that effusion. Choice C. Look at that liquid, man. Don't you make your dying to do with thoracentesis, I bet. Look at that thing. So choice C is a huge pleural effusion. What test would you do first to confirm that diagnosis? What test would you do first to confirm the diagnosis that it was a freely mobile pleural effusion? Decubitus films. Decubitus films. Let's see that liquid float around. Float around. What if you're not certain? Let's see it float around, float around, float around. Ready? Choice C is a huge pleural effusion. Most accurate test, thoracentesis. Let's put a needle on. Choice D. Choice D. Wow, look at that widened mediastinum. Wow. Choice D, widened mediastinum. Choice D, wow. If I tell you this person has chest pain, this is an aortic dissection. If I tell you this person has chest pain, that's a super emergency medicine disaster. If this person in choice D has chest pain, it might even tell you, going between the back to shoulder blades, difference in blood pressure between the arms. If they tell you severe chest pain and that EKG, it's aortic dissection, super emergency, super emergency. When do we get the cardiothoracic surgeon to come in on Saturday afternoon and Friday night and midnight on Tuesdays? Chest pain with this EKG in choice D, wide mediastinum, super surgical emergency. What medication would you use first for the dissection? Labetalol to decrease the pulse pressure. Labetalol to decrease the pulse pressure. Followed by nitroprusside to decrease the afterload. Choice D, beta blockers, nitroprusside, surgical intervention. Choice D, most accurate test, angiography. I never said I was going to do an angiogram, aortogram. What am I going to do? Well, to detect that dissection, which is better? Transesophageal echo, CT angiogram, MRA. Transesophageal echo, CT angiogram, magnetic resonance angiogram. Which one is better? The answer is they're equal, 90 to 95% all. They're equal, 90 to 95% sensitivity. Last one, and also by process of elimination. This is choice E, and I'm going to tell you what it shows. Very difficult. It shows straightening of the left heart border. It shows that the left main stem bronchus has been pushed up. Left main stem bronchus has been pushed up. Straightening of the left heart border, left main stem bronchus is pushed up. So what do you see in this x-ray, choice E? You see a straightening of the left heart border and the left atrium is pushed up the left main stem bronchus. Choice E in question 34 is the chest x-ray criteria for left atrial hypertrophy. Case E is the poster child for left atrial hypertrophy. Raising up the left main stem bronchus, straightening of the left heart border. Raising up the left main stem bronchus, straightening of the left heart border. Left atrial hypertrophy. For 80 years, all we had was EKGs and chest x-rays. Straightening of the left heart border, pushing up the left main stem bronchus. The answer is E. Okie dokie, let's look at our last couple of questions here. 25-year-old woman, straight on ahead question, what's the best initial therapy for mitral stenosis? Straight on ahead therapy. She's got fluid overload. She's short of breath. She's hemoptysizing. She has the big atrium pressing on her esophagus, causing dysphagia. She has the big atrium pressing on her recurrent laryngeal nerve, causing her to have hoarseness. She has a big left atrium, and we showed the possibility of AFib, which means that she's going to have the possibility of developing strokes. Big disaster. Rheumatic fever gives mitral stenosis. Mitral stenosis dilates the left atrium. The dilated left atrium presses on the esophagus, dysphagia, presses on the recurrent laryngeal nerve, hoarseness. Cause you to AFib, which cause you to have a stroke. But the first thing you can do is just fluid overload, diuretic. The first thing you can do is just fluid overload, treatment, diuretic, salt reduction, diuretic. I didn't say it do very much, but ACE inhibitors help with ventricular emptying. ACE inhibitors help with ventricular emptying. And this is a problem with fillings. You don't have a problem with emptying your heart. You have a problem with filling your heart. How poetic, right? So the answer is ACE inhibitors help us to empty the heart, and we want to have our hearts filled. So in order to fill that heart, well, now the lungs are too full, diuretics. So ACE inhibitors and ARBs do nothing for mitral regurgitation. Mitral stenosis, pardon me, for mitral stenosis. ACE and ARBs do nothing. Verapamil and digoxin might work for slowing the rate in AFib. That's the only thing for digoxin and verapamil. Next one. The patient develops palpitations. The patient develops palpitations, and the question is, which of the following is the best initial therapy? Second to last question. This EKG, let's look at this EKG and decide what it shows. This EKG, this is a narrow complex tachycardia with no P waves. Besides that, it's very irregular. It's an irregular, narrow complex tachycardia with no P waves, AFib. You know, you could in a way get this from just without even looking at the EKG. Maybe. The person comes in and they've got palpitations. Well, it happens to be that only digoxin here will slow heart rates. Digoxin's only use in mitral stenosis is to slow the heart rate in AFib to allow for more ventricular filling time. It's to slow the heart rate in AFib to allow for more ventricular filling time. Digoxin. ACE inhibitors and ARBs don't help with mitral stenosis. ACE inhibitors and ARBs help with ventricular emptying. This is the problem with ventricular fillings. Digoxin, beta blockers, and calcium blockers will help to slow the heart rate so there's more time for ventricular filling. Hey, does ventricular filling happen in systole or diastole? You know, when I was in medical school, ventricular filling occurred in diastole. And now? Yeah, it still does. So when the heart rate gets too rapid, what shortens? Is it systole or diastole? And the answer is what shortens is diastole. When does the heart fill? Diastole. Rapid AFib, you lose diastolic filling time. So when you have rapid AFib in mitral stenosis, digoxin, beta blockers, calcium blockers, digoxin, beta blockers, calcium blockers, slow the heart rate to allow for more ventricular filling time. Last question, finalmente. The person's been on diuretic and salt restriction, but they're getting worse, which is almost what always happens. Stenotic lesions need mechanical intervention. Aortic stenosis gets removed outright. Mitral stenosis doesn't get removed. It gets a balloon valvuloplasty. Not a finger. That's what it means by mechanical, manual mitral valve commissurotomy. That's what it means by manual. By the way, manual, not Manuel. Somebody came up to me last night and says, what is this problem with Manuel? Why do we have to have Manuel do the valve commissurotomy? Who is Manuel? I'm like, brother, it's not Manuel, it's manual. Manual. Oh, now I understand. So manual, do you know they used to chop through the chest and break up those commissures with the finger? Whoa, no. Circular salt through my chest. Spreading me open like a lobster, putting the butter and garlic sauce in there. No, thank you. Balloon valvuloplasty, amen. Mitral stenosis is getting worse despite maximum medical therapy, amen. May balloon valvuloplasty be with you. 20-minute procedure, up your groin, into your heart, out and done. Don't replace the valve unless they fail balloon valvuloplasty. And it doesn't matter whether it's pork or not, porcine. What matters is don't replace the valve until they failed valvuloplasty. Well, there is a lot in this case. There's a lot of detail and a very important case. This question concludes mitral stenosis. And the first part is, the lisinopril is always wrong because lisinopril, ACE inhibitors, and angiotensin receptor blockers help with ventricular emptying. And again, this is a problem with ventricular fillings. Next, you would not replace the valve until you tried to do a balloon. You balloon mitrals and you replace aortics. You can't balloon aortic valves too well because aortic valves, the mechanism is very different. Aortic valves, the mechanism is a calcification, whereas with mitral stenosis, the mechanism is fibrosis. So the mechanism is very different, and that's why we can balloon the mitrals. See, ballooning the mitrals is like your mother sending you, and presumably you're a guy, right? And your mother sends you underwear that's one size too small. And, now, a woman would just return it, but a man, he doesn't do that. A man, what does he do? He takes the elastic and he probably give it a stretch. Break some of the fibers. Dilate it up. That's what we do with this mitral valve here. So taking it from the top with mitral stenosis, number one, it's rare in the United States. Why? Because there's very little rheumatic fever. Why? Because there's a lot of antibiotics for kids' strep throat. Next, look for an immigrant who's pregnant because it has to come from places that have more rheumatic fever. Number two, when you're pregnant, you get a huge increase in plasma volume, which gets caught up in your lungs and makes you short of breath. Next, atrial fibrillation of all the valvular diseases has the largest left atrium. So it has the largest amount of strokes and the largest amount of AFib and the largest amount of dysphagia as the esophagus gets compressed by the left atrium. Recurrent laryngeal nerve compression. So the esophagus gets compressed for dysphagia and the recurrent laryngeal nerve gets compressed for hoarseness. Oh yeah. The best initial test is an echo for all valvular disease. The most accurate test is catheterization because it actually measures exact valve diameters and it actually measures exact pressure gradients. Diuretics and salt restriction might help a little, get some of that fluid out of the lungs. But ultimately, there's very little medical therapy for stenotic lesions. There's very little medical therapy for stenotic lesions. And ultimately, you have to do something mechanical for stenotic lesions. You balloon the mitrals and you replace the aortics. Now, this case also shows some interesting things on EKG and particularly on chest x-ray. The EKG has AFib. It's not very unique. It's just the most common to have AFib is mitral stenosis. Now, that chest x-ray is super unique. And remember, you can go back to these assets. You can go back to these images in this set, in this educational project as many times as you want. It's fantastic. You can go back to right as soon as I'm done, listen to the murmurs again. Looking at the x-rays, looking at the EKGs. You know, virtually everything you'll need, every image, every x-ray, CT, head MRI, every murmur and breath sound you could possibly need and more for step 2 is contained in here. Just go back now. Just go back now. Straightening of the left heart border, left main stem bronchus pushed up. That is the person who has mitral stenosis. Don't goof around in that auscultation. Mitral stenosis has been one of the most commonly asked ones when they play the audio tapes on step 2. Second, maybe you'll impress your attendings by being able to actually auscultate something. Remember in auscultatory maneuvers, more blood, more murmur, less blood, less murmur. With everything except mitral valve prolapse and IHSS. More blood, more murmur, less blood, less murmur, with everything except mitral valve prolapse and hypertrophic obstructive cardiomyopathy. Okay. So, how you tell in this one is that, remember, amyl nitrate decreases after load. Hand grip increases after load. That has nothing to do with mitral stenosis. Amyl nitrate decreases after load. Makes AR and MR, aortic regurg, mitral regurg, better. Hand grip increases after load. Makes AR and MR, aortic regurg and mitral regurg, worse because the hand grip's shoving the blood back. Squeezing the blood back, squeezing the blood back, squeezing the blood back.
What's the effect of lifting your legs up in the air on your heart? The answer is it increases venous return. Standing decreases venous return. More blood, more murmur. More blood, more murmur. Less blood, less murmur. For everything except IHSS and mitral valve prolapse. She's a young female. Why isn't it mitral valve prolapse? Because mitral valve prolapse is the wrong presentation. Mitral valve prolapse presents with atypical just pain, palpitations, appendix prolapse. It's a classic disease, mitral stenosis. It's an important one. It shows you how a disorder that used to be extremely common, it's virtually non-existent, can be eradicated, doesn't have to exist. And what's the effect of lifting your legs up in the air on your heart? The answer is it increases venous return. Standing decreases venous return. More blood, more murmur. More blood, more murmur. Less blood, less murmur. For everything except IHSS and mitral valve prolapse. She's a young female. Why isn't it mitral valve prolapse? Because mitral valve prolapse is the wrong presentation. Mitral valve prolapse presents with atypical just pain, palpitations, appendix prolapse. It's a classic disease, mitral stenosis. It's an important one. It shows you how a disorder that used to be extremely common, it's virtually non-existent, can be eradicated, doesn't have to exist. And a treatment that was originally developed for pregnant women, the balloon valvuloplasty, was developed for pregnant women. 50 years ago, we were doing manual commissurotomies. We're taking out the heart valve and replacing it with a piece of bacon, porcine, pork valve. Now we took a procedure that we developed for pregnant women to keep pregnant women out of the operating room. Balloon valvuloplasty, in, out, done. 20 minutes. Amazing, isn't it? Yes, it is. Well, we are in the amazing business, right? We, you and I, are in the amazing business. I'll see you in the next case. What's your favorite tocolytic premature labor? Magnesium. So you add magnesium to this VTAC person, particularly torsade. VTAC, what's your favorite tocolytic? Magnesium. What is premature labor? It's torsade of the uterus. What is torsade? It's premature labor of your heart. Chest pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion.